Range of motion, or ROM, is something that we often use in documentation. A lack of range of motion, or ROM, is usually indicative of a joint injury or a skeletal injury. The range of motion is the full distance that a joint can be moved. So you can actually have an extended range of motion, which would also be indication of a joint injury. So the normal range of motion for my arm is from straight to completely flexed. If my arm bends the other way, that would be an extended range of motion, which would be indicative of me having an elbow injury, or hyperextended. If I can only bend my elbow a little bit, that would be limited range of motion, which would also indicate a joint injury. Flexion is from the anatomical position, moving a distal point of an extremity closer to the trunk. All right? Like Arnold Schwarzenegger flexing. Right? I look just like Arnold Schwarzenegger when I did that, right? I would be back. Flexion is the opposite. All right? So, I'm sorry. Flexion is this. Extension is the opposite. So, in the anatomic position, remember Home Skippy on the cover, right? On the picture before, standing there like this. All right, in the anatomic position, all of your extremities are in the extended position. So if I bring my ankle or my heel up to my butt, that's what? Flexion. That's correct. Flexion of the fingers forms the hands into a fist. So flex, extend, flex, extend. All right. Extension is the opposite of flexion. It's the motion associated with the return of a body part from a flexed position to the anatomic position. In the anatomic position, all extremities are in extension, as I mentioned. Neck positions: when the patient is found in the supine position, you have neutral, which is the top position, flexed, which is the middle picture, and extended, which is the bottom picture. Let's stop and talk about this for a moment. In pediatric patients, you have an occipital prominence, which means the back of their head is bigger proportionally than it is in adults in comparison to the rest of their body. So to achieve a neutral C-spine position, you have to put padding under their torso. If you lay a child, especially a toddler, on a flat surface without any padding, then you're going to put their neck in a flexed position. Right? Okay, so how much padding you put is completely dependent upon how big of an occipital prominence the child has. For adult patients, they need to be in this extended position for what? For airway, to bring the axis of the airway in as straight a line as possible, particularly for endotracheal intubation, but even for just ventilation. So, oftentimes, I will stop to put something under their shoulders if I'm going to be intubating, and we're doing CPR like on the floor. I will stop to put a couple of sheets. We carry a couple of folded up sheets under the pad of the stretcher. You can stop, grab those, put them under the shoulders. It will cause this position, which will make intubation much easier. There's some confusion about the term sniffing position. Many people will call this, just the neck extended, the sniffing position. Other references, and some people will refer to the sniffing position as extended with the head forward. Okay, forward this way, and extended, rather than just extended. So realize that there's a little bit of ambiguity with the term sniffing position. It's different depending on which reference you're using. Internal and external rotation. Internal rotation describes turning an extremity medially towards the midline. External rotation is turning it away from the midline. Usually this term is used in pre-hospital medicine to describe the position of the patient's lower extremities. Their foot is turned out after injuries. It's external rotation. Usually denotes either dislocation anteriorly of the hip or femur fracture of the neck. rotation is posterior dislocation of the hip. Right. It can also indicate femur fracture. Rotation can also be applied to the spine. Spine is rotated when it twists on its axis. Placing the chin on the shoulder rotates the cervical spine. So when you turn your head, you're having rotation in your cervical spine. If I turn my entire torso, my bottom half stays still, then I'm rotating my thoracic spine or lumbar spine. Abduction and adduction. These are two that people confuse quite a bit. Abduction is when you move an extremity away from the midline. So abduction is this, adduction is that. Generally, it's at this part in the class where I make everybody stand up and flap like a bird. Right? So we can all say abduction, adduction. Abduction, adduction. It's important to bob your head like I'm doing too. So the way I remember this is the ADD part. Add. I'm adding to the torso. That's how I remember the difference. Okay. Do you all want to stand up and flap your arms like a bird? We can if you'd like. All right, guess we'll skip it today. Some different positions. Recumbent is the patient is lying down or leaning back. So typically recumbent means the position that you would typically be in your lazy chair watching a football game, your lazy boy. That's recumbent. Supine is when they're flat on their back. Right. Prone is when the body is face down. Face down. Typically, this term will be used to describe how we find a patient. The patient was found prone in the middle of the street at the MVA scene. The patient was found in the bathroom, prone between the toilet and tub. Obvious bullet wound to the back of the head. The patient was found prone on the football field, not moving upon our approach. Now, can you manage a patient that's in the prone position effectively? No, you cannot. Can you put a C-collar on a patient who is prone effectively? No, you cannot. So what do you do when you have a prone patient, a patient who presents in a prone position? Log roll them over if there's any evidence of trauma. If there's not evidence of trauma, you just roll them over or have. If they're conscious, tell them to roll over. You can't access their airway. You can't manage their spinal mobilization in the prone position. Believe it or not, this is a problem. This presents as a problem, happens several times a year. I arrive on the scene and an engine company has begun packaging a patient in a prone position. They find somebody lying on the street prone, they put the C-collar on or attempt to put the C-collar on with the patient's head either turned completely to the left or completely to the right, or worse yet, nose to the asphalt. No, no, no. Bad EMT. Take direct manual control of the head and log roll the patient. I have something else to say about that. And I don't know where this comes from, but it's so incredibly dumb that it makes me sick to my stomach. That noise actually does, in fact, make me a little sick to my stomach. Well, I completely lost my train of thought. There's so many things, yes, so many possibilities right now. I don't know. What was I even talking about? I don't know. Oh, I know. We're going to take manual control of the C-spine. All right. If I have a patient whose elbow is fractured, and I'm going to manually control that joint, do I grab their elbow? No. No, I grab their wrist and their upper arm, right, to keep it from moving, right? Okay, so does it make any sense at all to take manual control of the C-spine and grab somebody's neck? Is there any way that's preventing my head from moving in any direction if you're holding my neck. No, you grab their head. I think people are afraid to touch other people's hair.
Have you seen someone's hair?
You do have a valid point. I'm afraid to touch some people's hair. But for the most part, you're wearing gloves. So get over that. Grab them by the head if you're going to control C-spine and keep it in a neutral position. If it's not in a neutral position when you find it, move it to a neutral position. If while moving it to a neutral position, you hear funny noises or feel funny things, stop. Stop right there. If you feel resistance when you start moving their head, stop. Don't forcibly move it into the neutral position. It's okay if we can't put a C-collar on. It's all right. It's not worth cracking the vertebrae over. It is inappropriate to put your knee on their chest and take your hand and force their head into the neutral position. I wouldn't be talking about it if it hadn't been done. Just remember that. All right, Fowlers and semi-Fowlers. Fowlers is sitting straight up. What kind of patients would we put in the Fowler's position?
Breathing problem.
Yeah, breathing problems, particularly pulmonary edema, like we would find in CHF, right? Semi-Fowlers is when a patient who is sitting up with the upper body slightly leaning back. Pretty much the same as recumbent. All right, lying back. By the way, there's also left lateral recumbent and right lateral recumbent. That's when you're laying on your left side or laying on your right side. What kind of patients do we put in left lateral recumbent?
Extremely sleepy ones.
Pregnant patients. Pregnant patients. Pregnant patients. Why do we put pregnant patients in left lateral recumbent? Vena cava, right. Take the weight of the baby off the vena cava. Why do we put them on their left side instead of on their right side? That's exactly right, because of the way ambulances are designed. All the old ambulances had the cot completely against the left wall. So you put the patient on their left side, because if you put them on the right side, they'd be facing the wall of the ambulance. That's the only reason. If they want to lay on their right side and you have access to them laying on the right side, that's perfectly acceptable. Does everybody understand that? Wow. Trendelenburg. Trendelenburg is when the patient is supine, but their feet are elevated. We give patients with symptoms of hypoperfusion. There's been some debate about this. Apparently, some of the basic instructors have instructed folks that we never, ever use the Trendelenburg position. Okay, that's not true. Use it all the time. There's nothing wrong with putting somebody in a Trendelenburg position. It hasn't been removed from scope of practice, hasn't been removed from the educational standard. Here's the deal. At the basic level, we're assuming that you can't differentiate between the patient who's having difficulty breathing and not, so we just tell you not to do it, because it's detrimental to any patient who's having difficulty breathing, because the abdominal organs or the viscera put back pressure on the diaphragm, which makes it harder to breathe. It does, in fact, help patients who are in particular hypovolemic shock. The recovery position used for patients who have not sustained trauma to the neck or back. It's used to help drain fluids from the mouth. I don't recall ever having put anybody in the recovery position. As a paramedic, if you're having problems with airway, they're going to need to be on their back so you can manage their airway. You can't effectively manage a patient's airway in this recovery position. Now, if you have them packaged and they start power puking, flip them up on their side on the board. If they're not packaged and they start puking and they're unable to move themselves, turn their head to the side. All right? But when you get down to it, you're going to have to put them in a supine position to visualize their airway, suction, and put in an ET tube or whatever type of device you're going to use to secure their airway. Does anybody have any questions over anatomic definitions? Anatomic definitions. No questions. All right, there's going to be a unit test online that's going to cover basic chemistry and anatomic definitions, chapter 1, and the appendix having to do with basic chemistry. It'll be due midnight before you come back to class.